The shoulder is an elegant piece of machinery. It has the greatest range of motion of any joint in the body. However, this large range of motion can also lead to shoulder joint problems. Understanding the different parts of the shoulder can help you understand how the shoulder works, how it can be injured, and how challenging recovery can be when the shoulder is injured. The important structures of the shoulder can be divided into several categories. These include bones, joints, ligaments, tendons, muscles, nerves, blood vessels, and bursa. The bones of the shoulder are the humerus, or the upper arm bone, the scapula, or the shoulder blade, and the clavicle, or the collarbone. The roof of the shoulder is formed by a part of the scapula called the acromion. There are actually 4 joints that make up the shoulder. The main shoulder joint, called the glenohumeral joint, is formed where the ball of the humerus fits into a shallow socket on the scapula. This shallow socket is called the glenoid. The acromioclavicular, or AC joint, is where the clavicle meets the acromion. The sternoclavicular, or SC joint, supports the connection of the arms and shoulders to the main skeleton on the front of the chest. A false joint is formed where the shoulder blade glides against the rib cage. This joint, called the scapulothoracic joint, is important because it requires that the muscles surrounding the shoulder blade work together to keep the socket properly aligned during shoulder movement. Articular cartilage is the material that covers the ends of the bones of any synovial joint. Articular cartilage is about 1/4 of an inch thick in most large, weight-bearing joints. It is a bit thinner in joints such as the shoulder, which don't normally support weight. Articular cartilage has a rubbery consistency. It is very slippery, which allows the joint surfaces to slide against one another with very little friction. Articular cartilage functions to absorb shock and provide an extremely smooth surface to make motion easier. There are several important ligaments in the shoulder. Ligaments are soft tissue structures that connect bones to bones. The joint capsule is a watertight sac that surrounds a joint. In the shoulder, the joint capsule is formed by a group of ligaments that connect the humerus to the glenoid. These ligaments are the main source of stability for the shoulder. They help hold the shoulder in place and keep it from dislocating. Ligaments attach the clavicle to the acromion in the AC joint. 2 ligaments connect the clavicle to the scapula by attaching to the coracoid process, a bony knob that sticks out of the scapula in the front of the shoulder. A special type of ligament forms a unique structure inside the shoulder called the labrum. The labrum is attached almost completely around the edge of the glenoid. When viewed in cross-section, the labrum is wedge-shaped. The wedge shape and the way the labrum is attached create an elevated rim around the glenoid socket. This is important because the glenoid socket is so flat and shallow that the ball of the humerus does not fit tightly. The labrum creates a deeper cup for the ball of the humerus to fit into. The labrum is also where the biceps tendon attaches to the glenoid. Tendons are much like ligaments, except that tendons attach muscles to bones. Muscles move the bones by pulling on the tendons. The biceps tendon runs from the biceps muscle across the front of the shoulder to the glenoid. At the very top of the glenoid, the biceps tendon attaches to the bone and actually becomes part of the labrum. This connection can be a source of problems when the biceps tendon is damaged and pulls away from its attachment to the glenoid. 4 tendons connect the deepest layer of muscles, the rotator cuff muscles, to the humerus. Just before these muscles attach to the upper end of the humerus, they join together to form a single tendon called the rotator cuff. The rotator cuff muscles lie just outside the shoulder joint. These muscles help raise the arm from the side and rotate the shoulder in many directions. The rotator cuff muscles and tendons also help keep the shoulder joint stable by contracting and holding the humeral head tightly in the glenoid socket as the humerus moves. The large deltoid muscle forms the outer layer of shoulder muscle. The deltoid is the largest, strongest muscle of the shoulder. The deltoid muscle provides the power to lift the arm once the arm is away from the side. The main nerves that travel into the arm run through the axilla under the shoulder. 3 main nerves begin together at the shoulder: the radial nerve, the ulnar nerve, and the median nerve. These nerves carry the signals from the brain to the muscles that move the arm. The nerves also carry signals back to the brain about sensations such as touch, pain, and temperature. There is also an important nerve that travels around the back of the shoulder joint to supply sensation to a small area of skin on the outside of the shoulder and motor signals to the deltoid muscle. This nerve is called the axillary nerve. Traveling along with the nerves are the large vessels that supply the arm with blood. The large axillary artery travels through the axilla. If you place your hand in your armpit, you may be able to feel the pulsing of this large artery. The axillary artery has many smaller branches that supply blood to different parts of the shoulder. The shoulder has a very rich blood supply. Sandwiched between the rotator cuff tendons and the deltoid muscle are structures known as bursa. Bursa are everywhere in the body. They are found wherever two body parts move against one another and there is no joint to reduce the friction. A bursa is simply a watertight sac between two moving surfaces that contains a small amount of lubricating fluid.
Okay, we're going to go through the shoulder. These are the features that we will cover. The shoulder girdle is made up of 3 bones to attach our upper limb to the axial skeleton: the clavicle, scapula, and humerus. The view shows the anterior view, so you're seeing the subscapular surface. Notice how the lateral portion of the clavicle butts up against a structure from the scapula, while also going over another scapular structure. To better see this relationship, we'll look at the view of the top of the shoulder on the right. Notice this is the opposite view you get when you look at imaging. Imaging is looking at a person from their feet as if you're standing at the foot of a bed. This anatomy image, as is common with most anatomy diagrams, is from the opposite side, from the head looking down. Let's identify the notable features. The clavicle has a medially positioned sternal end and an acromial end that articulates with the scapula. On the scapula, the acromion is what the clavicle articulates. The other important scapular feature is the bony structure under the clavicle, the coracoid process. Additionally, let's name a few more structures on the scapula: the borders, medial and lateral, the inferior angle, and finally, the spine that runs posterior and medial from the acromion. Let's view the joint surface in the glenoid fossa outlined in purple. On the humerus, we see 2 prominent bumps, the greater tubercle and the lesser tubercle. Between the two is called the intertubercular groove, also known as the bicipital groove. We will look at the 2 most common views of the shoulder to identify the structures just reviewed: the AP shoulder on the left and the Y view on the right. First, pause this video so you can identify each of these structures on your own. Now let's do it together. Let's start with the acromial end of the clavicle. Now the scapular features: the acromion, spine, and coracoid process. Now let's find the medial and lateral borders. On a side note, the faint but distinct line of the scapular medial border can often be incorrectly attributed to a pneumothorax when evaluating a chest x-ray. This oval structure is the glenoid fossa, and we can nicely see the smooth head of the humerus facing it. Looking laterally, we can see the greater and lesser tubercles along with the intertubercular groove, which is more commonly called the bicipital groove, which we'll see shortly. The tendon for the long head of the biceps travel through here to a spot along the superior aspect of the glenoid fossa. Finally, the last 2 features I want to point out: the surgical neck and the anatomical neck. The anatomical neck is the part just behind the rounded articular surface behind the head of the humerus, while the surgical neck is below the tubercles. Here in this normal image, the head of the humerus is centered in the cavity. A posterior or anterior dislocation of the shoulder would be obvious from this view, which is why this view is ideal to determine the type of dislocation a person may have. Pause this video now to identify the listed structures on your own. At the top, we see the clavicle with its relationship with the acromion of the scapula. We also see the coracoid process underneath on the anterior side. Now look farther down on the gap between the ribs and the scapula. The scapular surface on this side against the body is the subscapular fossa. Up at the joint itself, we can see the outline of the glenoid fossa, the humeral head, and the greater tubercle. There are two main ligaments, the acromioclavicular and the coracoclavicular, which has two regions, if you want to be picky, that help connect the scapula to the clavicle. There are three muscles that also attach here. The short head of the biceps brachii in blue, the coracobrachialis in purple, and the pectoralis minor in green. An AC joint separation is the most common way to damage the coracoid process. On the radiograph, we can see the separation between the clavicle and the acromion of the scapula. Now look more closely above the coracoid process, and you can see a tiny bone fragment. This is an avulsion fracture where the coracoclavicular ligament tore and took some bone with it. This is an avulsion fracture where the coracoclavicular ligament we have seen previously that the short head of the biceps brachii attaches to the coracoid process. I would also like to identify the pathway for the long head. This image beautifully shows the biceps long head traveling up through the bicipital groove or intertubercular groove to attach onto a spot just above the labrum of the glenoid, which is a connective tissue ring that deepens the shoulder socket. The image on the left is the best image I could find of this relationship, but it happens to be a diagram for a type 2 SLAP tear, where SLAP stands for superior labral anterior posterior tear or lesion. What is important is the long head of the biceps tendon is the only intracapsular tendon, meaning that it goes inside the shoulder joint capsule. Normally, tendons and ligaments are positioned outside of the capsule. Let's now address the rotator cuff muscles using this lateral view. Sits muscles. We have supraspinatus, teres minor, and subscapularis. Although this image does not show all rotator cuff muscles, it's still missing infraspinatus. I like how it depicts the attachment of the three posterior muscles to the greater tubercle, noted by a G, and anteriorly positioned subscapularis to the lesser tubercle, noted by an L. Now let's look for these tendons and muscles on MR imaging. In this sagittal view, we see tendons of 5 of the muscles we have just discussed. Note the tendons are dark while the muscles are gray color. Without looking at the muscle labels, think about how you would identify anterior and posterior on this patient. The key feature is the acromion of the scapula. That is posterior. Now you get to identify the structures listed on the right. Pause this video to find them. Let's start with the muscles. In front and behind, we see the deltoid. Along the shaft of the humerus on the anterior side, we can see the biceps brachii muscle with the triceps on the posterior aspects. Now for the tendons. At the top is supraspinatus, and posterior to that is infraspinatus, and below that is teres minor. Anteriorly, the large muscle is subscapularis, while just above would be the long head of the biceps brachii. Now let's look at the axial view. We are starting high up on the shoulder at the point where we can see the head of the humerus and the glenoid cavity. Remember, the view we have is from the foot of the patient, looking up with the patient lying on their back, face up, so anterior is the top and posterior is the bottom. First, let's find the bony structures. Head of the humerus, glenoid of the scapula, scapular spine, and a bit of the clavicle. Now let's find muscles. Deltoid is the easiest as it's the most lateral. Supraspinatus is above the scapular spine, and subscapularis is anterior to that. The bicipital groove with the biceps long tendon in it. Now the joint structures. The head of the humerus facing the glenoid fossa. With these little black triangles at the end, now noted in yellow, those are the labrum, which extends and deepens the cup or articular surface of the joint. At this level, now we're a little bit lower at the diaphysis of the humerus and the slender part of the scapula. The deltoid is still the most lateral and wraps around. the bicipital groove with the long head of the tendons here. On the anterior surface, we see the pectoralis major, and just deep to it is pectoralis minor. Coracobrachialis is just lateral to it. Finally, back to the body of the scapula, on the deep surface is subscapularis, and posterior to that is infraspinatus, as we are well below the scapular spine at this point. Shifting topics to identify arteries. These are the arteries listed. Here's an arteriogram from the left subclavian artery. Notice the catheter that injects the dye located here. The two main arteries you should recognize are the subclavian, and just past the rib, it now becomes the axillary. We will look at the main branches off the axillary next. This schematic are sections of the axillary artery based on the position of the pectoralis minor muscle. Here we can see the pectoralis minor going over the axillary artery as it attaches to the coracoid process of the scapula, where section 1 we can see to the left and section 3 we can see to right, while section 2 is just behind the muscle. Proximal to the pectoralis minor, you can find the superior thoracic artery. Behind the pectoralis minor, you can find the thoracoacromial and lateral thoracic arteries. Beyond the pectoralis minor, towards the arm, is the subscapular and branches off that, the thoracodorsal and circumflex scapular. These are noted because they will be nicely seen on an angiogram following. Here is the angiogram of the shoulder. Let's look at our diagram and label what we know so far. First, this tiny vessel here, lined by arrows, is the lateral thoracic. This is way too little to be identified on an exam, but for comparison to those in wet lab, it's long and thin and runs just outside of the rib cage. The next vessel over, and the one that's much easier to see, is the subscapular artery, as well as its branches, the thoracodorsal to the latissimus dorsi muscle, and circumflex scapular as it wraps around the lateral border of the scapula. In this diagram of the upper limb arteries, let's look for two main arteries, the brachial artery and the deep brachial artery. This is an angiogram of the upper arm, with the arm out away from the torso more than the previous diagram. See the humerus? I'll outline the ends to help you out. The really thick, large artery is the brachial artery. The deep or profunda brachii is located here. See how it goes right close to the bone. Moving on to the forearm, in this diagram of the arteries, we start with the brachial artery coming down from the humerus to the antecubital region. Then it divides into the radial artery and the ulnar artery. From the ulnar artery is a short vessel called the common interosseous artery. That then divides to the posterior interosseous, where we just see a tiny segment, and the anterior interosseous, which runs on the anterior border of the interosseous membrane. This is an arteriogram of the forearm. We see the main arteries, brachial, radial, and ulnar. Off the ulnar, we see a short common interosseous and a distinct anterior interosseous, as well as a section for the posterior interosseous. Finally, we also can see the U-turn for the radial recurrent. Let's go over some basics of shoulder anatomy and imaging. The shoulder girdle is made of the 3 bones to attach our upper limb to our axial skeleton. These are the most notable features of these bones. On the clavicle, we have the sternal end and the acromial end. Just across from that is the acromion, also known as the acromial process of the scapula. The ligamentous connection between the scapula and the clavicle is the acromioclavicular joint, or AC joint. The protruding structure over the joint itself is another scapular structure, the coracoid process. Let's look at the important structures that attach to it. There are 2 main ligaments, the acromioclavicular and the coracoclavicular, which has 2 regions if you want to be picky, the trapezoid and conoid. There are 3 muscles that attach here: the short head of the biceps, brachii in blue, coracobrachialis in purple, and the pectoralis minor in green. An AC joint separation is the most common way to damage the coracoid process. On the radiograph, we can see the separation between the clavicle and the acromion of the scapula. However, look more closely above the coracoid process and you can see a tiny bone fragment. This is an avulsion fracture where the coracoclavicular ligament tore and took some bone with it. While we're looking at these structures, we definitely should address the grading of the injury to the acromioclavicular joint, which is the Rockwood classification system. The first 3 are a sequential series of strain, rupture, strain to complete dislocation. Rockwood 1 is a strain or partial rupture on the AC ligament, with the inferior border of the clavicle will be in line with the acromion, seen by the dotted line. Rockwood 2 progresses to a rupture of the AC ligament, but now the coracoclavicular ligament is strained. However, the inferior border of the clavicle does not extend above the superior border of the acromion. We can see that with the dotted line. Finally, in a Rockwood 3 is a complete rupture of the coracoclavicular ligament and the displacement of the clavicle from the acromion, where the inferior border extends above the superior border of the acromion. But the distance between the clavicle and the coracoid is not more than 25 millimeters. 4, 5, and 6 are all variations of a Rockwood 3. There's a complete disruption of the coracoclavicular ligament as well as complete rupture of the acromioclavicular ligament. Rockwood 4, the clavicle has completely broken away from the acromion and is now extended posteriorly. In 5, this is the same as in a 3, but now this time the distance here from the inferior border up is much more, and it's more than 25 millimeters. Rockwood 6 is anterior and inferior displacement of the clavicle. So what classification do you think is occurring in this image? This is going to be a 3. Okay, back to the anatomy features. The actual shoulder joint is the articulation of the head of the humerus and the glenoid fossa of the scapula. The articular surface of the humeral head relative to the shallow surface of the glenoid is what offers the very large range of motion as well as the instability of the joint. The soft tissue labrum deepens the cup or socket, which is not seen on the radiograph. On the proximal humerus, the 2 bumps are the greater and lesser tubercles. The term tubercle is a term specific to the humerus, but it can also be called a tuberosity. Between these structures is the intertubercular groove where the tendon of the long head of the biceps brachii fit in, also known as the bicipital groove. The long head of the biceps brachii travels up to attach the superior border of the glenoid cavity directly onto the labrum. This image also shows a SLAP lesion. SLAP stands for superior, labral, anterior, posterior tear, or lesion. This MRI shows a normal shoulder on the left and a SLAP tear on the right. Both MRI images have contrast, but the one with the damage shows a greater amount of fluid in the joint capsule, highlighting the gap or tear in the superior labrum. The first diagram showed the SLAP tear on the superior surface, which is not entirely correct. This diagram is a better representation of the SLAP region on the underside of the tendon insertion. Using this image to move to another common shoulder problem, the Bankart lesion, in the anterior-inferior rim of the glenoid. In this shoulder representation, we see the humerus, scapula, and the white labrum. Now the humerus has moved out of the socket and in the position of an anterior shoulder dislocation. Here's another view looking down at the top of the shoulder. Now the humerus has moved to the position of the anterior dislocation. This location can cause a tear in the labrum, which is called a Bankart lesion. From this lateral view, you can see the labral tear away from the glenoid cavity. If a piece of bone comes off the glenoid surface with the labral tear, now it's called a bony Bankart. Can you see the bony Bankart? It is a little piece of bone detached from the glenoid rim. On a radiograph, you would not see the labral tear. That would require further MRI imaging to evaluate. Back to the superior view of an anterior dislocation. Notice the impact area on the head of the humerus against the rim of the glenoid. This causes an impact fracture on the humeral head. This image more clearly shows the depression caused by the impact on the posterior superolateral humeral head, known as a Hill-Sachs lesion. Here's a great example of a bony Burkhardt from the glenoid and the resulting Hill-Sachs lesion on the humeral head. Here are two views of an anterior shoulder dislocation. The classic presenting sign is the patient coming in holding their arm awkwardly in front of them. On the image, we can see the shoulder is clearly pushed inward and not within the capsule itself or the glenoid cavity. And on the lateral or Y view, we can see how the head of the humerus is pushed now closer towards the torso. The posterior shoulder dislocation is less common and a little harder to detect. The main feature you hear from radiologists is that the humeral head and neck look like a light bulb with a uniformly round head. On the right are two different normal images, so you can see normal variations, but more importantly, see the tubercles laterally and more prominently round head region facing the glenoid cavity. On the right, we see it from the lateral scapula view, also known as the Y view. Normally, the head of the humerus is in the center of the arms of the Y. A posterior dislocation will show it shifted away from the ribs. Moving back to fractures, another common fracture in the shoulder region is shown here. Can you see it? What structure is damaged? The greater tubercle or tuberosity fracture. What muscles are attached? Supraspinatus, infraspinatus, and teres minor. Here we see two of the ones I just mentioned, supraspinatus and teres minor. Infraspinatus is not seen in this view, but we can see subscapularis, which is attached to the lesser tubercle. On the right is another radiograph of a greater tubercle fracture with the corresponding MRI on the left showing the extent of the inflammation and the area of damage. Let's review the structures on a radiograph again. The acromion and clavicle have a nice gap. The coracoid is a nice oval structure with a rim and it faces anteriorly. The head of the humerus overlaps the glenoid cavity. Now let's go through the main ligaments holding these bones together. The coracoclavicular ligaments attaching the coracoid to the clavicle, the AC or acromioclavicular joint. The coracoacromial ligament makes the roof of the coracoacromial arch. The glenohumeral ligaments are superior, middle, and inferior. The inferior glenohumeral ligament is drawn in a loop to allow for space when we raise our arm upward. Finally, let's walk through the attachment of the rotator cuff muscles and the biceps brachii. Finding the greater and lesser tubercles, these are the attachment sites for the rotator cuff muscles. Now the short head of the biceps brachii goes straight to the coracoid process, and the long head goes up through the intertubercular or bicipital groove to attach to the superior rim of the glenoid, fusing with the labrum. This is the only tendon in the body that is intracapsular in that it runs through the capsule of the glenohumeral joint. Starting superiorly, supraspinatus starts from above the spine over the coracoid underneath the acromion to attach the superior border of the greater tuberosity. Infraspinatus posteriorly under the spine comes around the humeral head to the middle portion of the greater tuberosity. Teres minor also coming around posteriorly to the humeral head, attaching slightly inferior to the infraspinatus attachment to the inferior border of the greater tuberosity. Finally, subscapularis located anterior to the scapula, between the scapula and the ribs, is going anterior to the humerus to attach to the lesser tuberosity or tubercle. Now we can try to find these structures on a sagittal MRI. First, figure out anterior and posterior. Here is the acromion, which makes this the posterior side. These black areas around the head of the humerus are tendons, specifically rotator cuff tendons. Superiorly, we see supraspinatus and anteriorly subscapularis. Here's a more nicely labeled image of all 4 of the rotator cuff muscles: subscapularis on the anterior side, supraspinatus on the superior portion, infraspinatus just below the edge there of the acromion as it goes into the spine of the scapula, and then a little thin sliver of a line for teres minor. A deeper view where we can see the muscle bellies first identify the bones. Here we see the acromion with its close relationship to the clavicle. Then on the anterior side is the coracoid process. Within the muscles, see the black dots? These are still tendon structures. This is the supraspinatus tendon. Let's name the muscles. We have supraspinatus, infraspinatus, teres minor. They kind of fuse together. They're 2 distinct muscles, but sometimes they look like one blob together. And then on the anterior side, subscapularis. These are the sits muscles. And here are your learning objectives for the shoulder.
The rotator cuff are a group of 4 small muscles within the shoulder, which originate from the scapula and attach to the humerus to provide dynamic stability at the glenohumeral or shoulder joint. These muscles are found deep within the shoulder, so here you can see the pectoralis major, deltoid, trapezius, and latissimus dorsi muscle, which are some of the large muscles involved in moving our shoulder. Underneath these, we can find the rotator cuff muscles. So our shoulder joint is made up of the head of the humerus, which sits within the shallow glenoid fossa. At any one time, there is only about 1/3 of that humeral head sitting in the glenoid fossa. This configuration allows lots of mobility of the joint, but in return, the shoulder joint sacrifices stability. To regain stability, we have 4 rotator cuff muscles, which can be remembered by the acronym SITS: supraspinatus, infraspinatus, teres minor, and on the anterior surface of the scapula, the subscapularis. In this tutorial, we'll discuss each one of these muscles in turn. The supraspinatus originates in the supraspinous fossa. As with many anatomical terms, the name of the muscle itself gives you a clue about where it's located. Supra refers to above, and spinatus refers to the spine of the scapula. So the supraspinatus sits in the supraspinous fossa above the spine of the scapula. The supraspinatus then passes underneath the acromion to attach onto the greater tuberosity on its superior facet. In terms of its action, the supraspinatus muscle in isolation creates abduction of the humerus. The muscle is innervated by the suprascapular nerve. The next muscle is the infraspinatus, so from its name we can tell that it's located below the spine of the scapula. And it sits within the infraspinous fossa. The infraspinatus muscle inserts onto the greater tuberosity of the humerus on its middle facet, just below the insertion of the supraspinatus muscle. In isolation, the infraspinatus muscle performs lateral rotation or external rotation of the humerus. It's worth noting that the supraspinatus and infraspinatus share a nerve supply derived from the suprascapular nerve, which comes off the superior trunk of the brachial plexus to supply both of these muscles. Next, we have the teres minor muscle. The teres minor muscle is located just inferior to the infraspinatus on the lateral border of the scapula. It then inserts onto the greater tuberosity of the humerus on its inferior facet. So just to recap, we've looked at 3 rotator cuff muscles so far: the supraspinatus, infraspinatus, and teres minor, which all insert onto the greater tuberosity on the superior, middle, and inferior facets respectively. In isolation, the teres minor muscle performs external or lateral rotation of the humerus. The nerve supply to the teres minor muscle is derived from the axillary nerve. The final muscle to talk about is the subscapularis. The subscapularis muscle sits on the anterior surface of the scapula. If we now remove the rib cage, we can take a closer look at this muscle. The subscapularis originates in the subscapular fossa, which is this depression occupying almost all of the anterior part of the scapula. From its origin on the scapula, the subscapularis muscle inserts onto the lesser tuberosity of the humerus, which you can see here. The subscapularis is the largest and strongest rotator cuff muscle, accounting for approximately 50% of the cuff strength output. When you isolate this muscle, it performs medial or internal rotation of the humerus. The subscapularis is innervated by the subscapular nerves, which is comprised of the upper subscapular nerve and the lower subscapular nerve. Both these nerves originate from the posterior cord of the brachial plexus. So that's an overview of the basic anatomy of the rotator cuff muscles. Just to finish off this tutorial, I would like to go through a few clinically relevant points relating to this muscle group. We've described the individual movements of the rotator cuff when each muscle is in isolation. However, in reality, the rotator cuff muscle works as a collective unit to provide dynamic stability at our shoulder joint while we are moving our arm. So when you're thinking about describing the action of this group of muscles, they in essence keep the head of the humerus in contact with the glenoid fossa during movement. They work to provide compression and depression of the humeral head at this joint. Because of the complexity of the shoulder joint and the relative weakness of this group of muscles, they are easily injured. There are many injuries which involve this group of muscles, which are commonly referred to as rotator cuff syndrome. This essentially is an umbrella term which refers to a variety of conditions affecting the rotator cuff. Sometimes this might be an acute strain or tear of the rotator cuff, tendinitis, which is common in younger athletes. So in sports which require repetitive overhead movements like bowling in cricket or pitching in baseball, certain occupations like painting and decorating, where there's a lot of overhead arm use, can also predispose to tears of the rotator cuff, the commonest of which would be a supraspinatus tear. The reason this is the most commonly torn is because if you look here at the acromion, which is essentially like a roof above the supraspinatus tendon as it passes underneath to insert onto the greater tuberosity of the humerus, when you elevate your arm, this space narrows, meaning it can get pinched, inflamed, and consequently tear. In middle age and onwards, the blood supply, which is already poor to this muscle group, can deteriorate even further, meaning chronic overhead use over years causes a degenerative tear, which can be thought of kind of like how an old rope frays over time. And so again, the supraspinatus is often most vulnerable to this injury, and both of these would present with pain and reduced power with abduction of the shoulder. Whilst there are several others, the other common conditions you might hear talked about is subacromial impingement syndrome. This condition relates to problems arising within this area here called the subacromial space. Common pathologies in this area include supraspinatus tendinitis from overuse or a subacromial bursitis. This here is the subacromial bursa. A bursa is just a fluid-filled sac. They reduce friction between surfaces, and we have many of them throughout the body which serve the same purpose. So in either of these conditions, what is happening is that because the supraspinatus tendon is inflamed, or the bursa is inflamed, it creates a narrowing of the subacromial space, meaning that when we elevate our arm, the inflamed structure, the tendon or the bursa, gets pinched and this causes pain. Sometimes neither of these pathologies are the cause of pain, and it can be small bony spurs projecting off the acromion, which pinches the bursa or tendon below it. The hallmark feature of this condition is the painful arc, where maximal pain is felt between 60 and 120 degrees of abduction. The pain is worst at this range because this is where the subacromial space is most narrow. But as any physiotherapist will tell you, a lot of shoulder injuries require rehabilitation of the entire rotator cuff, particularly in something like impingement syndrome, as strengthening the cuff means the humeral head will be better compressed and depressed against the glenoid, so you can get more clearance between the humerus and acromion during movement of your arm.